And we're recording. All right, thank you. Well, thank you everyone for attending today. This is an Acadicus roundtable discussion with Dr. Nicholas Slamon to talk about his he recently completed a research study that was published in the Curious Journal of Medical Science on teaching pediatric airway intubation using VR simulations using Acadicus with inexperienced junior fellows and residents. And I'm going to switch over to my slides here briefly. There we go. So just to set the scene here, first of all, Acadicus is a virtual simulation platform that provides tools and a library of content for creating learning experiences. And this is the platform that Dr. Slamon used in his study. Oops, sorry. There we go. And this is the study that was published on December 13th of last year, virtual reality simulation for pediatric airway intubation readiness education. Because it's published in Curious, which is one of those open access journals, you can get the full article without having to subscribe or pay anything. So that is a link in the slides here to the actual study in the I gave there. And these slides will be available to anyone also as well. They'll be available for you to download and use however you wish. And who we have on the call today are our three handsome gentlemen. And I'm going to introduce each of them in turn, and then let each person introduce themselves briefly. But Dr. Nicholas Slamon is a pediatric intensivist and fellowship program director for pediatric critical care at Nemours DuPont Hospital for Children. He's also clinical professor of pediatrics and pediatric critical care medicine at Thomas Jefferson University Hospital. And Dr. Slamon, why don't you introduce yourself briefly too? And I'll just go through in turn, and then we'll hand it over to you.
Sure. Thanks, John and John. So as John's introduction said, I am a pediatric critical care doctor. I think in 2020 with COVID, anybody who watched the news or turned on their computer probably knows what a critical care doctor or an intensivist is at this point. So people who are sick enough to be in the intensive care unit need a specialized set of physicians to take care of them. Things that they may need include, a breathing tube or intubation, endotracheal tube, mechanical ventilator, central line insertion, and pressor support to support the heart. Basically, how I describe what I do to people is if you have failure or impending failure of the heart, the lungs, or the brain, you're probably going to be coming to me. And I take care of pediatric patients, so anybody from birth to about 21. We occasionally have people a little bit older than that. And in this pandemic situation, a lot of pediatric hospitals have been asked to provide some care for adults up to sometimes 30, 35 years old. Thankfully, Delaware has not been really hard hit at all with COVID. So although we do have that medical ICU for adults set up, I've yet to have to provide any care for adults. And that's probably a good thing because I'm a little rusty on some of my adult diseases. But it comes down to, again, heart, brain, and lungs. And despite the fact that kids are a little different than adults, most of it's pretty much the same.
Great, thank you. And John Bruchot, you're the CEO of Arch Virtual. Why don't you introduce yourself?
Sure. Yeah, I'm John Bruchot, the founder and CEO of Arch Virtual, and we're the developers of the Acadicus platform. I'm actually trained in architecture, so came to virtual reality with an interest in using it for the practical applications of visualizing architectural environments, and started doing a lot of medical hospital and clinic environments, and eventually got into the actual hands-on simulation, and have had the opportunity and the privilege of working with a lot of visionary innovators in the space like Dr. Slamon, and really hoping that Acadicus can be of service in the industry to provide opportunities in medical simulation.
Awesome, thank you. And lastly, I am John Lester. I often go by the nickname Pathfinder because that is a handle that I've used on Twitter since the beginning of Twitter. And also it's a handle that I've used in other virtual environments in the past as well. But my background, actually, my original background goes all the way back to healthcare. I worked in the neurology service at Massachusetts General Hospital, initially focusing on doing neuroscience research focused on neurodegenerative diseases, mostly Parkinson's, some Huntington's disease as well. And over the years, I got more interested in actually using technology and medical informatics technology and online tools to create educational experiences for patients and medical students. So I created a whole group of online patient support groups for patients dealing with different neurological conditions, and also did some course development of and creating some online educational resources at Harvard Medical School, where people could actually go through a case-based medical education experience online with role playing done by different faculty and so forth. And this was this was all part of my interest in creating educational experiences that leveraged online tools. And over the years, I got much more interested in emotional bandwidth, ways of increasing also the immersive fidelity of an experience. So I started getting involved in 3D simulations, 3D environments, 3D renderings of spaces with multiple people in them. And that's what a lot of people know me from when I hung up my lab coat, although I still like to wear it around the hospital because, even though I'm not working in a wet lab anymore, I was writing grants to National Library of Medicine and NIH and things like that for online medical education tools. And I actually worked, I ended up also working at Linden Lab, the developers of Second Life, for a number of years. I was there to help people who were using the platform for educational purposes. And then over the years, I also then, after that, I got very interested in online simulations, still the more immersiveness and things, the VR headsets when the Oculus Rift came out. That was a huge interest to me, when I saw it pop up on Kickstarter, the original Oculus. And did some bespoke design of simulations for nursing training and multi-user simulations using game engines like Unity and Unreal Engine and things like that with VR as well. And at Acadicus, what I'm focused on with Acadicus is, as the director of community and business development, I'm really focused on ways of helping our community develop in terms of community of best practice. And so all of the amazing research and work that's being done, the educational work that's being done in Acadicus, I'm really focused on helping those people connect with each other and also help them achieve not just their own goals, but their initial goals, but think of new goals that they could achieve that never were possible in their minds because they didn't realize they were able to even attempt them, right? So the idea that, at the stage we're at with Acadicus is we have a lot of people doing amazing projects like Dr. Slamon, and a core part of Acadicus's philosophy is sharing content with everyone else, and the idea of encouraging interdisciplinary collaboration to develop more rich and complex and powerful simulations and things like that. So that's my take on this, and it's good to have. I think it's really good to have all of our perspectives around the roundtable as we do these in the future. I'm really looking forward to having interdisciplinary and multidisciplinary roundtables talking about the future of VR and medicine and healthcare education. So I'm going to actually go back to my slides here real quick. There we go. And I go by the name John or Pathfinder. So I respond to if you say Pathfinder, if someone says Pathfinder in a room, I will respond. So you can call me either. You can call me anything you want. Just don't call me late for dinner. So just to set the stage before we hand things over to Dr. Slamon to talk about the study, the environment that we're talking about is an immersive simulation. So what you're seeing on the screen here is a 2D visualization, a 2D image of this, but it is a fully immersive 3D experience that you can interact with, both in using VR goggles as well as non-VR mode. So just using your computer and your monitor. And in this environment, you can see here Dr. Slamon doing some ECG work here. And this is actually, notice it says a recording. And so what you can do is actually in the platform, And in the study, it talks about using recordings. You can record everything that you do in the simulation. So Dr. Slamon was, placing these things on the patient's chest, and to do the ECG, and he was recording himself doing it, so students can come into this environment, and here in this case, John is in the environment live, and he's basically playing back Dr. Slamon doing this procedure and interacting with the objects and placing the leads and so forth. And you can see over on the left where it says student, this is someone who is in non-VR mode. This is somebody who's sitting on their laptop, on their screen, watching the environment. And they can, all these people, well, not Dr. Slamon, he's a recording, but the student and John could interact with each other. So this is an idea of like how this all works, right? You have people in VR, and you can always see what they're looking at, and their hands are, their hands in their positions, and they're pointing at different things, and they're manipulating objects. And as a student, you can actually manipulate objects as well, but not with the, the fidelity, obviously, of using the VR equipment. And this is another example of a setting in the environment where Dr. Slamon is showing a technique. And the wonderful thing about this too is that, again, you can change your perspective. And so here you can actually see somebody from the perspective of being in VR, manipulating objects. And if a recording is playing back, the student can put, they can walk over and basically look at the scene from the eyes of the instructor as the recording is playing back. So as you think about the educational possibilities of the platform, and of this VR application in general, this is really an immersive way to inhabit the recording of an instructor walking someone through a procedure. So I'm going to end here and go back to the stopping the share here. So I'm gonna hand it over to you, Dr. Slamon. Can you introduce the study and how this all came about, and how the results worked out?
Sure. Thanks, John. So I think I just want to set the stage for, I'm sure we have kind of a variable audience with people with lots of different backgrounds. And just to set the stage, students that enter medical school go through medical school for 4 years, and they spend a lot of that time in the first 2 years sitting in a lecture hall, taking notes and not really seeing patients. And then they go on rotations in their third and fourth year and get some patient exposure. But the day you graduate medical school and you have that diploma and you're now a doctor, doesn't really mean that you can just go out and start to practice. So most people will pick a specialty and do what's called a residency. And a residency in pediatrics is 3 years. A surgery residency might be up to 6 years. But what I deal with is pediatric residents. So they're in their first 3 years of being a doctor, and they're specializing in pediatrics, and they're doing lots of different rotations. Some of them are inpatient, some of them are outpatient, but they spend a month with us in the ICU. And then after you've completed that 3-year residency, you may say, well, I want more specialty. I want to be a pediatric cardiologist, or I want to be a pediatric intensivist. And that means another 3 years of training, which is called a fellowship. And usually half of that, 18 months, is clinical experience, and half of that is research. So what we decided to do in this experiment, or this study, was to see if we could make a comparison between novice pediatric intensivists, so fellows who are within their first couple days of being a fellow, so they just graduated their residency. And we also lumped into that group some pediatric residents who were rotating through the ICU. And what we wanted to do was see what their exposure would be like for something that's probably our biggest procedure. The thing that provokes the most anxiety is a child who can't breathe, and a child who has impending respiratory failure. They may be breathing very slowly because of a drug ingestion. They may be breathing very rapidly because they have pneumonia or bronchiolitis or COVID. But at any rate, their breathing is ineffective. They're not exchanging carbon dioxide effectively. They're hypoxic. Their oxygen levels are low, and they're going to need help to continue to be alive. And that help usually comes in the form of insertion of a breathing tube and putting them on a ventilator. So it's kind of the most anxiety provoking procedure we do. And it comes with a lot of pieces. There's a lot of equipment, there's a lot of subtleties, and there's a lot of training that goes with that. And the hypothesis of this study was that if I used something immersive like Acadicus and made a recording that showed them all the steps and really describe to them all the pitfalls that they might come towards in setting up for an intubation, a pediatric intubation, and went over all the pieces of equipment in detail. And I made a recording of that and then put them in the headset, let them watch that recording, experience it. And as John pointed out, in Acadicus, they can really be in the video with me. So they're not just watching a recording, they're handling all the equipment with me. The hypothesis was when they were done that, we would test them outside of VR and see how much do you recall, how much do you remember, how many of the steps did you get right? And the hypothesis was that they would perform as well as my upper year fellows, my second and third year fellows who have set up for pediatric intubation probably 100 times by the time they're done their second and third year fellowship. So, I think the point that John made is a subtle one, and I want to come back to it because I'm sure there are people in the audience that are saying, well, okay, great. Well, why don't you just make a YouTube video of yourself with the equipment and demonstrating the steps, and then they can just sit down and watch the YouTube video. And that's true. We could do that. But I think the difference that comes with the immersive 3D sim is that I'm not having those students and fellows and residents just sitting down and watching something on a computer. They're putting on the headset and they are part of the simulation with me. So they're watching my recording pick up a laryngoscope, and then they can pick up the laryngoscope. Oh, I have to hold it like this. I have to hold it in my left hand. I'm supposed to check and make sure the light works. Okay, the light seems to be on. They can pick up the breathing tube. They can make sure the cuff inflates. They can make sure the curve is set properly. They can measure it out and make sure that they have the right size. They can simulate bag mask ventilation. So supporting the patient until we're ready to put the breathing tube in. We take a mask, put it over the nose and mouth of the patient, and deliver oxygen breaths and make the chest go up and down so that they don't desaturate when it comes time to put the breathing tube in. So they're not just seeing the avatar, the recorded avatar, do all the steps. They're then doing the steps themselves. So all told in the study, they would spend about 20 minutes or so in the headset. They'd watch about 15 minutes of the video, the recorded video, doing some of the steps along with my avatar. And then they'd spend another 5 minutes or so kind of picking up all the equipment. Okay, I need a bag and mask. I need suction. I need a breathing tube of the proper size. I need an oral airway. I need an NP airway. I want to make sure I have an Untitled CO2 detector to make sure that the tube's in good position. And then we take them out of the headset, bring them into another room that had a traditional plastic mannequin with a box full of equipment, and said, set up the room to get ready to intubate this mannequin. Try to remember all the steps that you learned, walk through the checklist, and scored them. And what turned out to be the truth for the experiment, which was small, we had about 7 or 8 people in the VR group, and then we had about 9 of our critical care fellows who were upper years. But what we found was that they scored appropriately. The novice airway setter-uppers, for lack of a better term, remembered as many steps as my upper year fellows who had done it probably 100 times by then. So we thought the conclusion we came to was that VR is really an appropriate vehicle to teach medical education and simulation. And, I think a lot of people that come from a traditional sim background want to know, does this replace traditional mannequin sim? Does this teach them how to intubate? Do they feel what it's like to pick up the laryngoscope? And my answer to that is always no. That wasn't the goal of this study. And I don't think it's the goal of Acadicus or VR sim to get down to the fine, granular kind of, what does it feel like to put a central line wire in? What does the weight of a laryngoscope in your left hand feel like? That's not the point. The point is to show the steps, step by step, get familiarity with the equipment. How does it work? What do you do with it? And then some of those physical features until we get, better haptic gloves that give you the real sense of what something feels like in your hand. There's still a role for having a traditional mannequin simulation lab. And again, kind of being mindful of not knowing what everybody's background is in my audience. To learn medical education, you can go through that 3 years of residency and 3 years of fellowship, and you hope that you come across lots of different patients with lots of different diseases, and you are exposed to lots of things to help you learn. But the reality is in 2020 that volumes, especially in pediatric hospitals, are down. So your exposure to sick patients is less. And the other reality is that nobody's going to let a novice doctor practice a potentially dangerous procedure on a patient, whether it's a child or an adult. So, there's that concept of kind of seeing an expert do it, and then doing one with assistance, and then going on to teach one to someone else. And that still exists in medical education, but simulation over the past 30 years has grown astronomically to not be a replacement, but to augment medical education. You've only done 5 intubations in your life. Well, come into the sim lab and we'll help you get another 50. We understand a mannequin is not the same as a patient, but it's pretty good. And it gives you the sense of what the steps are and what the feel of the equipment in your hand is and what you should do to troubleshoot. And I think, part of the problem with traditional simulation for me was always the realism effect, that I never felt like it was real. It always felt like no matter how they tried to dress it up, it was still a plastic mannequin. And if I didn't get the breathing tube in, it's a plastic mannequin that is not alive anyway. It's going to be okay. I'll just try again on the plastic mannequin. So I've always been pretty, I don't want to say obsessed, but obsessed with that kind of video game culture where could we make a medical simulation, a medical video game where you really felt like you were in the game. You were the doctor performing the procedure in real time. There were high stakes. There was pressure if you didn't get it right. And, what I found with putting that headset on and being in an immersive environment like Acadicus is it really ratchets up that reality factor. And I think the students in our study felt the same way, that kind of all the outside light is blinded out. The sound coming to you through your headset is in your headset. It's not coming from the room outside, and you're transported. And John, if you wouldn't mind putting the screen share back up of that last slide with the boy in the pediatric ICU.
Sure. There we go.
So this is a carbon copy. This is point for point accurate of what our ICU looks like. So I took snapshots early in our partnership with Acadicus and sent them to John Bruchot. And within 2 weeks, he constructed our pediatric ICU down to the wood grain on the walls and the color on the floor and the windows and the equipment. Everything is where it is in our ICU. And what I always tell people, and John, I'm sure, is tired of hearing me say this, but I think it drives home the point. When I spend a lot of time in the VR headset and I'm in this virtual ICU, it's so immersive that I forget where I am. And, the example of that is when I'm in the real ICU and I'm setting up for intubation, I might lean on the head of the bed because I'm waiting for the nurse to bring the medication, or I'm waiting for the respiratory therapist to bring the ventilator in and set it up. And when I spend too much time in the headset, I start to lean on the head of the bed that doesn't exist and find myself almost falling over because I'm not in the real ICU. I forgot. So it's that level of reality in terms of the equipment and the environment and the animated patients that we've created. So from my standpoint, for my money, there's a role for traditional simulation for sure, but VR simulation, I think the sky is the limit, and the reality factor is already there and can only get better. So this study that we did, I think, proved our point that VR simulation could be used for medical training. The students, the fellows and residents quickly picked up, because they come from that culture of gaming, that put them in a headset and give them hand controls, and they were zooming around the room very quickly. So there wasn't a steep learning curve of, I don't know how this works and where am I and what do you do? They were telling me like, oh, I want to teleport over there. Yeah, that's how I do it. Or I want to pick that up. Okay, I use that side grip instead of the front grip. So they quickly picked up the skills. They immersed themselves in the video and participated instead of just watching. They started picking up tools themselves. And then when we translated them back into the real world and said, all right, do it again, show us what you can do, they had great recall that was comparable to our advanced fellows who had been doing this over and over again in their jobs for the past 2 and 3 years. So the takeaway for me was, yes, it's a small study, but more work has to be done in VR with medical education, because I think it's the next thing. I think it's the next frontier.
Nice. Thank you. Well, speaking of who our audience is, I have a poll that I am going to launch. It's a quick yes/no questions, 7 questions. I'm going to launch it right now. Asking things like, do you work in healthcare? Do you work in education? Have you ever tried VR? Have you ever used VR for educational goals? Are you currently using VR for educational goals? So if folks could answer those questions, I'll also report the results live, I guess. But you mentioned, Dr. Slamon, you said, the key to this training exercise was to familiarize the learner with the sequential steps in the equipment setup. And that's something that people who aren't in healthcare may not realize, like, how complex that is, right? Can you talk a little bit more about like how complex that is, a situation, for learners in healthcare, in not just your situation with pediatric intubation, but other procedures as well?
So we picked this particular kind of scenario, this clinical scenario, again, because it's the one that makes people the most nervous. Watching a pediatric patient kind of turn blue in front of you and not being able to get a breathing tube in is, the thing that makes everybody's heart race and makes everybody break out in a cold sweat, because that's the thing that's going to lead to the child's death. We purposefully chose not to get involved with the intubation itself. So the physical placement of putting the breathing tube in the trachea, we said we're going to do that at another time with another kind of setup that John and his team have already created. And you've seen some slides alluding to that with the operating room scene that you put up on your slides. But we wanted to focus on setup. And I'm notorious for preaching to my fellows that, I was never a Boy Scout, but being prepared goes a long way. And having all the equipment that you need, even if you don't end up needing it, is a lesson that I've learned the hard way over the years. So the worst thing ever is I'm bag mask ventilating the patient, and I'm not getting good chest rise, and I've sedated and maybe even paralyzed the patient, which would be a real no-no. And now I can't move the chest, and I need an oral airway because I think the tongue is too big and it's obstructing the breaths that are going into the chest. And I don't have an oral airway. I didn't set that up ahead of time. I didn't ask anybody to get it. And then it becomes a mad scramble as the patient turns blue. Everyone can hear the audible saturation meter go beep, 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 beep. Then it's getting slower and the heart rate's getting slower. Hey, can somebody go grab me an oral airway? So I really wanted to drive home in this scenario that being prepared was of the utmost importance. And these were the key pieces of equipment that you needed. And these were the key kind of ergonomic steps that you needed to take. So things that you don't think about. I want to put a breathing tube in the patient, but the bed's too low. And I have to kind of bend over and stoop. And now my back's starting to hurt. And I can't really reach the patient because he's down in the middle of the bed. I've neglected to move him upward. I didn't put a towel under his shoulders to get his head back. So even though I'm trying to give air and breaths through the mask, it's not going anywhere because his chin's down and he's obstructed his airway. Those are all kind of steps that you learn over a lifetime of critical care practice through residency, fellowship, and then your attending practice. But these were all steps that we said we can put this into a virtual reality simulation, avatar-driven video, and we can let other people not have to make those mistakes. Make the bed height something comfortable to you. Move the patient to the head of the bed where you'll be able to easily reach them. Put your bag and mask to your left-hand side so you can get at it. Have an assistant that can hand you the breathing tube when it's time and provide a little bit of lip retraction to give you some room to get it into the mouth in the child, which is small. So we kind of said we can build all that in. You don't have to make our mistakes and learn the hard way and potentially put patients at risk. So it really was detail driven. Not only the equipment, but the positioning of the patient and how the room should be set up in this video to kind of start to communicate those early steps of getting ready to intubate a patient.
Interesting. We've got our poll results back. Interesting. About half the people half the attendees work in healthcare. Almost all of them work in education. Almost all of them have tried VR. Most of them have used VR for educational goals. About half of them are currently using VR. And about half of them have used a real world simulation lab in the past, and about half of them are currently using a real world simulation lab in the past. So that's interesting. Those results are really, let me make sure I've captured that there. Awesome. Close that. Now this study, you conducted this study back in July of 2019. I'm curious of two things. How has the overall educational landscape, well, we know the world has changed quite a bit since 2019. How has the overall educational landscape from your perspective changed since then, due to COVID and, more distance learning? And also, how has the Acadicus platform changed since you did this, since you did the study in July 2019?
Those are great questions. I think the COVID stuff is the elephant in the room. So early on, all in-person mannequin-driven sim labs were closed. Ours was closed from March when the COVID kind of lockdown happened, and I don't think they opened again in any kind of form until about July. And then when they opened in July, it was something that was not an in-person, all right, let's all gather around the mannequin, 6, 8, 10 residents or medical students, and let's practice together because of the social distancing constraints. So even with masks and gowns, our hospital has been very kind of forward facing that, great, you're wearing a mask, but 6 feet of distance is still what CDC is recommending. You can't all cluster around in the same room around the mannequin. So it really put a damper on anybody's ability to do any practice together. And what we refer to usually, most of our simulation sessions are called mock codes. So not just a tutorial like, hey, let's set up for intubation, but this is a patient with a clinical scenario of X. Maybe it's respiratory failure or supraventricular tachycardia or bronchiolitis or status epilepticus, seizure disorder. But pick a clinical scenario, and then the wizard behind the curtains in the sim lab is making that mannequin desaturate and changing their vital signs, and slowing down their heart rate and making their heart stop. Or if the mannequin has palpable pulses, the pulses go away and then CPR begins, and there's this whole kind of dance, this orchestrated dance with a code leader and a procedure resident and a nurse and a respiratory therapist, a whole team of people that practice their individual roles to try to resuscitate that mannequin and resuscitate the patient. And all of that went away because of COVID. And then in July, when some of the sim centers opened up, what they tried to do was set up some cameras, have 2 or 3 people in masks and gowns that could be the the Confederates within the scenario, and then run something like what we're doing here with a Zoom, where you'd have the mock code leaders, the residents who are trying to learn, how do I do this? They're remote, they're at home, or they're in an office, or they're on a phone somewhere in a conference room watching a screen, and they have a couple camera views of the mannequin, and they try to physically direct the people in the sim room via Zoom, hey, can you start chest compressions, or can you give a bolus of saline, or can you deliver some epinephrine? And I think some of that idea came from what we had already been doing with Acadicus. So Acadicus has grown tremendously from 2019 in terms of the environments that you can work in, the number of avatars that have been created, the patient avatars, the amount of medical equipment that you can handle and use has grown astronomically. And in working with John Bruchot, we created our own Zoom mock codes. So again, have 15, 20 residents and fellows on Zoom, and then have myself and John and Stefan as avatars in the VR environment. And we're here to do your bidding. This is patient X. He's 17 years old. He fell off a roof. He came in complaining of chest pain, and now he's unresponsive and has no pulse. What would you like us to do? And our Zoom code leader then says, John, I want you to start chest compressions. Nick, I want you to get to the head of the bed and start masking the patient, get ready for intubation. Stefan, can you draw up some IV fluids and some epinephrine and deliver that? And we run a mock code. What I think is advantageous about that is, again, even though the code leader was via Zoom and observing just like they were observing the mannequin simulation folks, there was a level of realism and immersion that was even greater in VR. And then in simulation in general, there's something important that, again, I think a lot of people on this call understand already, but I'll explain it anyway. That debrief session where the mock code is over and it's time to say, well, these are the things we did well. These are the things we could improve on. These are the spots where we think things might have gone wrong. Let's educate and talk about and learn about what we might have done better. How could our team communication have been better? Maybe we didn't understand the physiology of what was going on with the patient. And that's where Acadicus, in my mind, has a real advantage in that you can have all kinds of hidden items in the scenario. So the mock code may involve getting a chest x-ray. And in the, in the real medical simulation mannequin-based sim center, you might have a computer rig to pull up a chest x-ray, or you might have a physical chest x-ray there. But often the simulation leader is just going to say, yeah, the chest x-ray shows he's clear, or the breathing tube's in good position. In Acadicus, we can scan in an x-ray, pop it up when the time is right, or delay popping it up to make the scenario go on and increase the suspense a little bit. Chest x-ray folks are on their way, but they're not here yet. You're going to have to keep making decisions without the chest x-ray information. You're going to have your mock code leader ask you for other things. Well, can someone listen to the chest? Or it looks like his chest is not rising symmetrically. Maybe he's got a pneumothorax on one side. And then at that key point, we can bring up that x-ray that shows got a large right-sided tension pneumothorax. And again, during that debrief, one of our scenarios was an asystolic code. And what are we supposed to kind of remember? The H's and T's. So, things that could cause asystole often lead to the heart being empty, the right heart being empty, then the left heart's empty and there's no cardiac output. So things like hypoxia, things like hypothermia, things like tension pneumothorax, things like cardiac tamponade. There's a whole list of 5 H's, 4 T's, or 5 and 5 at this point. But we created these posters in Acadicus where during the debrief session, we're going to pop those open. All right, well, here are the list of H's and T's on a huge poster that they can see in Acadicus. And what I feel and what I've always believed in medical education is that there's a link between auditory learning, visual learning, and physical interaction with your environment, whether that's writing something down and taking notes, or doing chest compressions yourself, or picking up the laryngoscope and putting the breathing tube in. All of those different types of learning, when combined together, for me has always locked it in place better than if I just watched a video or I listened to a podcast but couldn't see anything. There's something about tying together hearing, vision, and touch that I think makes human beings better at what they do when they train. So having gone through the scenario and seen the patient, seen the x-ray of the pneumothorax, listened for breath sounds and not heard them, and then seen that list of H's and T's and said, pneumothorax is one of the list of H's and T's. I have that locked in. The next time a patient has asystole, I'm going to be thinking about that. I'm going to remember that. So, for me, the VR environment in Acadicus has an advantage over a traditional sim lab where they'd have to say, all right, well, I'm going to have to make a poster for these H's and T's, or maybe I can get one of those flip boards and I'll write it on there, at the end during our debrief. I feel like it's a lot of extra preparation that would go into a traditional sim lab, where Acadicus, it's simply scanning in a poster and making it be revealed at the right time during the debriefing session.
Interesting. Yeah, I do think that there are plenty of things that you still can't do anywhere else but in a physical simulation lab, especially around haptics, physical feedback of certain things. That's I think a lot of what I always like thinking about augmenting, how things can be augmented by different technologies. And I think that it's really interesting to hear, where some of the strengths are of a physical simulation lab, and then where that drops off, and then where it can be picked up by something like a VR based simulation lab. And I think there's just so many opportunities to explore that, because there's no one tool that's right for everything. That's the danger we get in, especially, when you have a shiny hammer that you love, then everything in the world looks like a nail. And we have to be always conscious of that tendency of human beings to do that. And it's funny, the more that you talk about your perspective on things, my neuroscience background starts kicking in, and I start thinking about, mirror neurons, man. And perceptual immersion leading to, that's how the brain remembers things. The more environmental cues that you have going on at the same time, the more the memories are locked in. That's how our brains are built biologically. And I think the idea, the importance of situational awareness in an educational experience, with a VR environment, you can create such visual fidelity. And the Acadicus platform in particular is extremely focused on high visual fidelity. It's not cartoony at all. It's always, the decisions are always like, well, there's a trade-off if we make it look more real, but we got to make it look more real. That's always the decision, right? Not cartoony, more fidelity, so that your brain at that point, it becomes close enough so that your pattern recognition neurons go, it's real. I'm going to treat it as real. I'm going to try and lean on that. One thing that you mentioned that was really interesting, I wanted to ask you about is, you were talking about, it's fascinating. You're talking about using Zoom, people on a Zoom call, talking to people in a virtual simulation. And, so now we're talking about intersections, right? We're talking about intersections of different technologies, different learning tools. I think that, that just kind of blows my mind, because, you start thinking about how you can connect these different technologies. I've seen researchers doing things, like in VR, they will then make a YouTube video and then embed that educational content in something else. Can you maybe speak more about what your visions are around potential intersections of other technologies? And I know I've just got to mention this because this blew my mind too. You've done studies of physician biometric parameters using wearables during live critical care activities. What about studying biometric parameters in VR simulations? I mean, what are your thoughts around, those kinds of things as well?
Yeah, I think, both of those are really good points. If I had my druthers, Zoom has been a great tool, and I like what it can do. I like how we've interfaced it with Acadicus. I still feel like, I think very similarly to the traditional sim folks, that they'd like to open their sim labs back up, get rid of the masks, and have everybody clustered together around the mannequin doing a mock code again. What I would love is that, kind of the next step in medical education is not when you get admitted to NYU Langone on your first day of medical school, they hand you a laptop or they hand you a an iPad. I want those students to get a VR headset and get a laptop that can drive a high fidelity simulation like Acadicus on day one. And, I mentioned earlier, those students spend a lot of their time in the first 2 years never meeting a patient. They've tried to improve that, there's these little seminars that they do on a Friday afternoon where they get to meet patients or they get to meet actors, but there's still a lot of what they do is read, study, repeat, take a test, sit in a lecture hall. With each student having their own VR sim, how great would it be for them early on to put a headset on and say, I've never met a patient, but I'm going to do the pediatric airway readiness scenario today, or I'm going to do an adult status epilepticus seizure scenario today, because someday I'm going to deal with that. And they can do it as many times as they want. They can mess it up as much as they want because they're a first-year medical student. They don't know that much clinical medicine, but they're going to learn some through being in a VR headset and practicing it in an environment that seems so real that it's hard for them to tell the difference. I think the other thing that's important to remember that I didn't stress enough is that these mock code scenarios are really based on teamwork. So how's the communication between the code leader and the airway resident and the bedside nurse and the nurse drawing meds out of the code cart And is there closed loop communication? I'd like a dose of epinephrine, 0.1 cc's per kilo of the 1 to 10,000, please. Drawn up, has that been given through the IV? Has it been flushed? Yes, it's been flushed. That kind of feedback amongst the team of an order's been given, an order's been executed, an order's been completed, and there's confirmation of that. And Zoom allows us to do that because we have, this audio and video feedback. But what's even better is when you have multiple users in a headset, all in that same Acadicus room together. And maybe one of them is on the West Coast at Stanford Medical School, and maybe one's on the East Coast in Boston, and maybe one's in Texas at Baylor. But all those folks could be in Acadicus, in a mock code together, bringing their own learning from whatever coast they're on, their medical school background, and they can all work together, communicate as if they're in the same room in real time. They can see each other's avatar, they can hear each other, and they can watch each other execute the steps and coordinate that. And there's not enough that can be said about practicing that teamwork when you're in a medical code situation. Having the equipment and not having, to ask for anything and being prepared is important. But how do the cogs and the pieces of your machinery work when everything gets kind of crazy and the patient's dying? How well do you coordinate swapping out your CPR people? So somebody's doing chest compressions, they start to get tired. Code leader says, all right, you're out, next person's in. Being able to do that in real life and coordinate and practice that is important. Acadicus gives you the ability to do that. Now, you might not bump shoulders with each other as you trade spots, but you're going to have to coordinate. All right, you get out of the way and you move in and the next person start. All that teamwork is something that you can really repeat in a VR simulation, which is great.
Awesome. We have a question from the attendees about hand controllers. The pictures show hands and gloves, but controls don't have 5 fingers. Maybe actually, John, maybe you could speak to that, as the developer of the platform.
Yeah, so we're using controllers. The headset that Dr. Slamon was using was the Oculus Rift, and with the Oculus Rift, you have hand controllers. So these are basically tracking the movement of your hands, but there's also sensors that actually can have your you can actually point at things, or you can squeeze different buttons or triggers that are on the controller. And like one of them, to pick something up, you just basically squeeze the handle, and there's a grip button on the handle of the controller that allows you to pick up the object. So basically, when you see his hands moving around in the simulation, he's using these Oculus Touch controllers.
And so there's actually the subtlety for those folks who have never used one, right? Is that the controllers can not just sense if you're pressing a button, but they can sense if your finger is just resting on the button or if your finger's not on the button at all. There's a capacitive sensor. So you can use you can point with one finger. It knows when your thumb is up, but only, I think there's the Valve Index has more subtlety around being able to track other finger movements. But I think that's so there's some finger involvement, some finger some of it is involved. I think one of the interesting technologies down the line is to look at things like with the Oculus Quest, the ability to have controllerless tracking. So you can actually see it's just tracking your fingers and different levels of flexing of your fingers without any controller at all. It's just mapping it with the system's mapping it in real time as it's moving in front of the headset. So very interesting. So do you have what are your plans, Dr. Slamon, for like additional research? Where do you go from here?
So the first study was really kind of set up, and what we're planning now and what we have IRB approval for and what John is in the midst of kind of building for us is more assets. So more mannequins that do more. So mannequins that breathe and stop breathing, mannequins that seize and stop seizing, mannequins that have all of the basic pediatric advanced life support and ACLS algorithms for heart rhythm disturbance. So SVT and VTAC and VFib and torsades and asystole and bradycardia. we're building all those algorithms, and we are going to try to run a mock code simulation study. So I think we're still going to probably have Zoom as the perspective for the mock code leader. And then we've purchased 3 headsets, 3 laptops that will have those folks, myself, one of the other critical care attendings, and 2 of our critical care fellows as avatars in the scenario that will be in there to execute the instructions of the code leader. And of course, one of those folks in one of the advances that Acadicus has created will be in what's called ghost mode. So one of those avatars will be invisible to the Zoom observers, invisible to everyone else in the room. They'll have full control over the panel that will be able to set the heart rate, set the blood pressure, set the saturation, end-tidal CO2. They'll have control over the patient. They're breathing or not breathing. Their eyes are open or closed. Their perfusion is good or they're gray and mottled. They'll be able to change the rhythm. So their heart rate went from sinus tachycardia to bradycardia to asystole. And what we propose to do is run our residents, our pediatric residents, which we have about 45 of those, through those scenarios twice. So there'll be the mock code leader once early in their rotation and then once later in their rotation, hoping to see differences as they've gone through the year and gain more medical knowledge, that they've improved their overall score as the mock code leader in these various standard scenarios that we're creating. So we're really looking forward to that. I think the other innovation that we want to work with John on that won't be part of this next study is creating a virtual hospital. So right now we focused on being in a room. So we're in the PICU room or we're in the emergency department room. But what happens in reality in our pediatric hospital, when I'm on call, at least, maybe because I'm unlucky, is I may be in a PICU room doing a procedure and my cell phone goes off and says there's a text to a rapid response on the 4th floor that I'm expected to respond to within 10 minutes. And then the phone rings and says, there's a patient coding in the ER, they'd like your assistance. So what we'd like to do is to be able to kind of go in and out of virtual environments within Acadicus. I'm in the PICU room. All right, the breathing tube's secured. I'm going to hand this off to the resident. And I've just been called to the ER. I'm going to go through a virtual door leading out of the PICU that takes me to the emergency room. And now I'm in the emergency room for that next scenario. So we feel like we might in VR be able to run multiple mock code scenarios in multiple locations at the same time. And that really is what can happen in the ICU environment, where you're expected to be responsible for most of the hospital. Maybe there's something going on in the OR. Maybe there's something going on the floor. Maybe there's something going on in the ER. And we want to give the person in VR the sense that they can move from one environment to another when called or summoned.
Wow, that's awesome. Yeah, really ramping up the level of the art of the possible, right? Of what you could do. This is something that you couldn't do in a physical simulation lab, but is eminently possible in a virtual simulation lab, like a holodeck. That's my dog Stella, by the way. Her brain is full. She doesn't want to hear me talking anymore about this. This is a slight tangential but important question in my mind is you published in Curious. It's an openness. I don't know how to pronounce it. Curious.
I think it's curious to make it sound like you're curious scientific.
I'm Curious George, yeah. But it's it's one of those newer open access peer-reviewed medical journals, and I love how the articles are available to everyone free as soon as they're published, and they're also published under a Creative Commons attribution license. And I'm always thinking about how the way all this stuff will advance is if we get people publishing about doing research and publishing their results. Why did you choose to publish your study there, and what do you think of the platform?
So I think there's a couple different comments on that. Some of the traditional journals in critical care, emergency care, and so on, it's almost become COVID or nothing these days. If the article isn't specifically about COVID, I think the market has been flooded with people researching COVID and writing about it and trying to get published in COVID. So, we approached some of those traditional journals early on and they were like, yeah, this isn't about COVID. That's cool and all, but no thanks. Curious offered a couple different things to us. One, I think you have to be wary these days of kind of open access predatory journals. So they send you an email, hey, esteemed Professor Slamon, we've read your paper on this. We'd like you to write a paper on that. And you don't find out till much later that the article that they want you to submit comes with a cost of you giving them $2,000 to get the article published in their open access journal. And they kind of try to justify that as saying, well, we got to publish it and offer it for free, and we got to make money somehow. So you're going to pay us to publish your research. So we didn't want that. And Curious doesn't do that. It's free open access. The other thing we wanted to make sure is a lot of the predatory journals, when you pay to play, they don't have it reviewed by anybody. So Curious platform makes sure that your article is reviewed at least 3 times in a peer-reviewed setting. Nice. So they ask you to submit names of people that you think could be potential reviewers that might be experts in the area that you're writing about. So I submitted some names of, kind of the who's who of IMSH and simulation and pediatrics, but it turns out, they have their own bank of expert reviewers as well. So our paper ended up getting reviewed by 5 different reviewers instead of 3. And then they come back at you with, we didn't like this. This wasn't phrased properly. You should think about your analysis in terms of that. Your discussion section is missing a paragraph that speaks about this. So you're asked to make corrections and make the paper as good as it can be. It's not just kind of, okay, well, you paid us $2,000, it's in. No one looked at it, no one cares, and no one will see it again. So we kind of like that, those options from the Curious platform. And then Curious sends you emails, after it's published, trying to get you to distribute the article as far and wide as possible, because they want other people to read it and then critique it. So they want this kind of ongoing evolution of the paper, that not that it gets read and never seen again, but people are reading it and saying, yeah, I like that they did that, but why didn't they think about, one of our people in the Zoom chat said, well, why didn't you compare pediatric residents in VR to the same skill pediatric residents without VR? And that was definitely an option. That would have been, the hypothesis of, we hypothesized that the VR residents will be better than the ones that didn't get VR. We decided to make a different comparison. We knew that the upper year fellows knew what was going on. They know how to set up for airway. We considered them the experts. And our hypothesis just happened to be, with a little bit of VR training, we can make these guys score as well as the experts. So it was just a different way of doing it.
Nice. That's good. It's good to know, because for folks who are watching this video who are thinking of publishing their results, that's really useful. Thank you for sharing that. Let's see, we're on the hour. John, did you have any additional questions for Dr. Slamon?
Well, the only thing I wonder about is, again, coming at this from my perspective, trained in architecture, I don't have a lot of background in medicine and in, healthcare. And I'm just curious your perspective on working with us. I've often talked about, the fact that we really don't want to write or any code or build anything just because we think it's cool. We want to make sure that we're building something that's going to be effective and useful. I use the curling analogy, like we want to stay ahead of the puck, just kind of sweeping, just to kind of make sure that we're providing what you need. Could you speak to the experience of providing that input to us, and if there were any roadblocks or any opportunities for improvement going forward?
Sure. As I said in the very beginning, just a series of snapshots and iPhone videos of me kind of taking a picture of what our PICU room looked like turned into, less than a month later, an almost carbon copy virtual environment of our PICU. I was really amazed at the level of detail, and I was amazed at the speed with which the Acadicus developers can kind of crank things out. So, early on, they had a breathing tube that had no curve in it. It was just straight, and it had the balloon inflated. And I'm like, well, guys, the balloon, like, you can't get it past the vocal cords if the balloon's inflated. Why is the balloon inflated? And I'm like, oh, we didn't know. Like, we saw a balloon there. We thought you should put air in it. So those kind of interactions are like gratifying for me, because it makes me feel like, man, you're really smart. You're an expert. You know what's going on. But it's always amazing to me how fast the Acadicus team picks everything up. Sometimes they'll come to me and say, well, yeah, we made it like this, but that doesn't seem to make sense. Is that how it's used? And I'm like, no, actually, it's not how it's used. You guys are right. it should be curved, and the balloon should be deflated. So these guys are, on top of their game. They're really good at what they do. And I personally haven't met with any real roadblocks. Their attitude has always been, yeah, that's cool. We should do that. The more real, the better. The faster we can get it out and get people using it, the better, it is. I think the roadblock for me is that, again, the number of people in the community that have a high-powered laptop and a headset is not where I want it to be. I'd love to have most of my fellows and residents have these in their house, and I could say, COVID's really hit us hard, but let's jump into Acadicus this afternoon. We're going to do a mock code without Zoom. We're going to meet, in VR face to face. How great would that be to have more than just 3 headsets going on? I'd like everybody to be able to jump into the VR environment and do that. Acadicus, of course, has no control of that, other than I think the more people see how cool this is and how realistic it is, I think more people will want to get on board.
That makes sense.
Yeah, very interesting. I know we're going a couple minutes over, but I wanted to, there was a question from one of the attendees asking about the idea of eyeglass mounted video cameras worn by, surgeons in a real life ICU, and then maybe playing it through a VR headset to allow students to have, an additional POV. Any thoughts, Dr. Slamon and John, about those kind of future possibilities, combining, the POV of someone in the physical world doing a procedure and then bringing that into a VR setting?
Yeah, I mean, I'll let John speak to that as well, because I know he has some experience with 3D cameras. There was a presentation from, I think, NYU at the virtual IPSSW, which is the International Simulation Society presentation in November or October, where they had taken 3D cameras, mounted them on tripods, scanned the environment, which happened to be the emergency room. So then you could walk around that 3D environment. You couldn't interact necessarily with the pieces of equipment in there, but you could kind of navigate your way through that 3D environment. So instead of generating a virtual reality, cartoon picture of the emergency department in Unity, they had an actual 3D picture of it. So pluses and minuses, it ramps the realism up to it's the real ER. There's no telling the difference. The downside for me was, well, the code cart that I can see in the ER, I can't open the drawers, I can't grab the defibrillator, I can't do anything with it. So they did a lot of things with their 3D environment where they would have little pop-ups and cues saying, all right, well, the patient has this now, what do you want to do next? So it still worked for them. But for me, there's that hands-on, kind of interplay between vision, auditory, and hands-on, being able to touch something in VR that for me makes the experience more rich. But there are definitely people working with live camera VR.
I think, yeah, it's a good layer, I think, to be able to use virtual reality to witness and observe something that's been recorded by an expert surgeon that's doing something, or an instructor or physician. And we have done things with the environment side where we do a 3D scan of a delivery room, for example. The delivery room that we're going to be adding to Acadicus coming up pretty soon for a neonatal simulation that we're developing was a 3D scan of an actual facility. So you've got the accuracy of the proportion and the scale of the environment, and the lighting and the realism of that. But then we sort of, it's like a hybrid. Now we have 3-dimensional objects, so you can actually interact and do things. So to try to get that interactive piece combined with the realism that you get with the 3D scan, there's a lot of possibility there going forward.
Nice. It's interesting, the role of agency, the importance of agency in these environments, and I think that's one to wrapping things up, the idea of being able to manipulate your environment is very critical to learning and memory. And the idea of in a Acadicus recording, you could be playing back the recording, and the instructor could be using a piece of equipment, and you could literally then take the thing out of their hands and then start using it yourself. You could take the object out of the hands of the recording and actually manipulate things. And so there are really interesting ways that you can, there's value in passively watching a 3D recording, but the ability to have agency within a recording, I think, is bringing things to a very interesting next level of perceptual immersion and agency in a learning experience. Thank you. Well, thank you for those of you who are who attended and who stuck with us a little bit longer, as we're 7 minutes past the hour. I'm going to share my final screen here, and while that's coming up, I just want to thank all of you for attending. Thank you, Dr. Slamon. Thank you, John Bouchot. And this final slide here is, let's see here. Oops, I'm sorry. Make sure. Oh, I had a little glitch on my end. Here we go. There we go. You can see the slides you can download off of a bit.ly link here. I'll be sending this out to everyone who attended. Please sign up for our newsletter on Acadicus.com. You can, if you go to Acadicus.com, just scroll all the way down on the page and you'll find the sign up. You can reach us at support@acadicus.freshdesk.com. And we have a Discord community, which we're building out to, to people who are using our platform, and ways of we're looking for ways of fostering collaborative opportunities among people, as well as answering people's questions. So if you're into Discord, feel free to pop in and join us. And I'd say that's about it. Thank you everyone for attending, and I will stop the recording. And Stella says it's time for me to give her lunch.
Thank you, everyone. Thank you very much. Thanks, Nick.
Thank you.
Thanks, guys. Thanks for having me.
Thanks, John.
Have a great day.